afternoon, everyone. Today we'll be discussing about the practical aspect of offloading. Our conference is all dedicated about the diabetes, and diabetic treatment is incomplete without offloading. So over here, the offloading means to take away unwanted pressures from high pressure areas of foot to prevent or save foot from complications. So over here, this is very important thing that whoever clinician or a doctor who regularly see diabetic patients, for them to understand that offloading is not only for the diabetic foot ulcer, it is important for all diabetic patients, because most of the time in my clinical practice I see patients when some other complication has already happened. We don't see very regularly a normal kind of diabetic patient where their feet have a very limited or a minor neuropathy changes, or there is no neuropathy changes, because that is the ideal time that we can save their feet from getting complications. So over here, the prevention is better than cure. Why to wait for the foot ulcers? Because most of the time we are always treating patients at the stage of small or big foot ulcers. Even we know that all the diabetic patients are always at the threat of getting neuropathy, like motor neuropathy, sensory neuropathy, autonomic neuropathy. We know that motor neuropathy can lead to foot muscles imbalance and can lead to deformities, and they are prone for the foot ulcers. Whereas sensory neuropathy is there are lack of protective sensation that make the foot at the higher risk. And when there is autonomic neuropathy is there, decreased sweating lead to dry skin, and dry skin can anytime get crack of blisters and foot ulcers. So the small callus formation, if we see in our OPD, a normal callus formation, we just take it as a hard skin that everyone gets. But in diabetic foot patients, you cannot ignore this small calluses, because anytime it can have a subcutaneous hemorrhage and can convert it into the ulcers. So do not wait for the ulcers. Timely referral, it is very important. So here we are taking the clinical evaluation of diabetic foot, which exactly tell us that when to send patients for the offloading. The first one is year of diagnosis. Year of diagnosis is very important. Like if the patient is diagnosed as a diabetes since more than 3 to 5 years, they should be sent for the offloading, even if they have any other complication or not. Then the foot ulcer history, because many times we treat deep foot ulcers and we ask the patient, they already have in past they have a small blister or the ulcer which has been recovered with the dressings. But during that time, the doctor or clinician may have not explained them the importance of the offloading. And then the second time, they convert into the life-threatening foot ulcers. The third one is foot deformities, because the diabetic foot are more prone to foot deformities like the clotose, hematose, and hematose and the flat feet, charcot foot. So all this type of foot deformity patients can easily get ulcers, and they should be sent for the offloading. Then if you see a small concallus ulcers, if we see a patient entering in our OPD with the improper footwear, they should be explained at that time only and should be sent for the proper footwear. Then there is a problem with the foot pulses, foot temperatures is affected, or foot sensations are affected. At that time, patients should be sent for the offloading. Over here we can see the foot deformities, different type of foot deformities, like hallux valgus. First picture is hallux valgus, and the second one is the clotose, then hematose, then the fourth one, there is a prominent metatarsal is there, and the fourth one is charcot foot deformity. In all these feet, if you observe one thing, they are quite wide. And in India, we are lacking wide footwear in our market. The most of the footwear that we get normally in the shoe stores, they are mostly normal width or the narrow width footwear. And this type of foot deformity patients, whenever they are wearing normal type of sports shoes, they keep getting friction and can convert into the blister and the ulcer. So if we see any such thing, then should be immediately sent for the proper diabetic footwear. And one of the things missed over here is the flat foot. If the diabetic patient has a flat feet, then it should be immediately sent for the offloading, because whenever there is a flat feet, there is a high medial loading and can lead to blisters anytime. The next is improper footwear. Over here we can see that how that improper footwear can convert into the blisters. In this clotose, charcot foot, when there is the improper, they are wearing improper footwear, they easily convert, or there is a path for the ulcers. So we should not allow our patients to go in that path of the ulcers. And this is the third one, very, very important thing, because there is a systemic disease. Diabetes is a systemic disease, and they are more prone to swellings and all. So swollen foot, it is like a balloon. Like the inflated balloon, you just scratch it with your nail and it will burst. The same way, when there is a swollen feet, the swollen feet can easily get punctured with a smaller forces. So definitely all the swollen foot, they are wide, and it needs space in the shoes. And in all market shoes, there are no space available for this type of footwear. And in the next picture, you can see how the straps can reduce or hamper with the circulation and can lead to complication in the diabetic foot. So screening at the primary stage is very, very important, because whenever we are missing that screening, then only our patients convert into the complications. So this type of form, a diabetic foot screening form, which include a very minor thing, and it do not take much time for the clinician to just fill out this form. And this type of form should be available with all the doctors treating diabetic patients regularly. And after filling this form, by categorizing the feet into a no risk, high risk, moderate risk, that type of category is very important, because when we are showing patients, okay, you are at the high risk, so this meter, whenever we are suggesting them, it get noticed in their brain that I am considered in the medium risk or the high risk. So it become important for them to follow whatever we suggest. So always categorize the patients in the risk. The same way that whatever clinical evaluation we do, there are digital ways that we can find the plantar pressure, because whatever the clinical evaluation that we do, that we have understood, and many times we are unable to explain the patient. So for them, we need to show something. So digital ways are there that we can show our patients. These are the baropedometry platform, which shows which are the high pressure areas. It gives us an idea that what is the amount of pressure on the first MTP, second MTP, fifth MTP. So specific area pressure we can recognize that with this platform. And we can also have an idea that how much is the forefoot pressure in compared to the rear foot. And if there any heel strike or gait problem is there. So all the analysis that we get on this particular software, we can explain the patient. Because in clinical examination, we have already understood. But for patient, it is very important to see on the screen that what is exactly happening to their feet. So these are the best platform for the diabetic patients. The other ways of the digital ways to find plantar pressure, these are the laser scans, but it do not give dynamic control. It just give a static analysis. Then the third one are these are the smart insoles. They have the sensors in the insoles, and that can be put into the shoes, and patient can wear the shoes and walk on the treadmill and can find which are the pressure areas, what is the amount of pressure during the heel strike phase, and all the phases of gait. So till here we have understood that when to send or when to show patients that they need offloading. So now there are different type of offloading. There are various methods for the offloading, like total contact cast, removable cast walkers, therapeutic shoes, custom insoles, surgical offloading, and all these methods, according to the patient's foot ulcer or foot type, we need to decide that which particular offloading method is best for this particular patient. Like the initial total contact cast and the removable cast walkers, like diabetic foot walkers, they all of three give good immobilization, and these are usually recommended for the big ulcers, non-healing ulcers. The principle of this particular shoes are, like in first image we can see that our body weight is directly transferring onto the foot, and in foot it is concentrated on the high pressure areas. But once patients wear this type of walker, diabetic foot walker shoes, or total contact cast is given, the surface area is increasing. We are giving total contact till leg. So whatever pressure is coming into the foot, it is divided into the larger area. So the pressure coming on the high pressure area will be now quite less, and it will allow the ulcers to heal. So these are usually used for the non-healing ulcers. And this type of offloading shoes are frequently used in treating diabetic foot. So here are, like you can see, the first one having heel is off. So this is particularly ulcer shoes for heel ulcers. Then over here on the right side corner, we can see there's a 4-foot ulcer shoes. But this 4-foot ulcer shoes or the rare foot ulcer shoes, it cannot be used for the longer period of time. We usually suggest the patients, like whenever patients come to my OPD with 4-foot or rare foot ulcers, it reduces the weight or it take away the pressure very effectively. But if it is used for longer period of time, then the posture and the gait get affected. So I usually recommend that for 1 month, 2 months, patients is switched on to this type of shoes till some amount of healing happens. And after that, it should be switched on the rocker bottom sandals, where it promotes propulsion. Heel to toe gait, it is very, very important with very important and applied with this rocker bottom sandals. So after this ulcer offloading sandals, they should be transferred into the rocker bottom sandals, so their gait posture won't be affected. And if the patients come to me with only callus, corn or small problems, then I would always suggest shoes over sandals, because whenever they are wearing right type of diabetic shoes, the area is completely protected and they don't get complications in the future. Here are the characteristics of the diabetic shoes. Like all diabetic shoes should have a deep and wide toe box. It should have a good fitting with the velcro and the lace. Should have a firm and depth ankle. Whenever there is a good depth in the shoes, it supports the ankle properly, and it will not allow the foot to go inside or outside. So it will not create any high pressure. Then the firm EVA sole. The EVA sole is also very important because it get a good shock absorption, and then the pressure on the feet also will be lesser. Now with these good shoes, good insoles are also needed. See, this is the first insoles. It is with the removable pegs, normally available everywhere. We can just take out the pegs wherever is the high pressure areas, but it will not give a total contact. So for the temporary offloading, we can give insoles with the removable pegs. But the ideal is giving a total contact kind of insoles and total contact with offloading kind of insole. And they can be made either computerized or either manually. Computerized is the ideal way or is the latest way to make the insoles, where we can design the insoles on the software and then the machine can do the carving and we can get the insoles. And manually also it can be created. So now there are also temporary methods that can help in the offloading, including this type of pads, like a single wing pad, double wing pad, or U pad, or the donut pads. If this type of pads, we make it with this very simple equipments like this, and it is fixed in the right place of the sandal, it can reduce considerable weight from particular area, specifically high pressure area. But these are all temporary methods, because we have to keep in mind that whenever we are offloading that particular area, the cider or the edges of the ulcers, they are converted into the high pressure areas. So it should be used for few days or a month. Then after it should be removed. The next are the offloader for the dressing. The same way we have added in the sandals, the same thing can be used with the dressings. And with the dressing, we can fix this type of pads and it can offload the areas. The next one is the latest one, the intelligent plantar pressure offloading insoles. This study is done in 2023 in Switzerland. This is an inbuilt battery, and the insoles have a pressure sensor ports. And in that particular ports, give reminder to the patient and then give alarm to the patients. But this still needs lots of research. It is in the very initial stage. The last, the patient friendly is the key. Because whatever offloading method we are suggesting or we are giving, if it is not accepted by the patients, then we won't get success in treating diabetic foot. So whatever treatment method that we are giving, it should not hamper patients' mobility. It should be budget friendly to the patients, easy to wear for the patients, and managed by themselves. Because many times I have seen if patient is not able to wear complicated footwear and they are dependent on other relatives to make them wear footwear. So when that is the question, patient many times stop wearing the footwear. So patient friendly is the key. So take home messages: prevention, prevention, prevention. As sir also said, that prevention is very, very important. If the patient is sent for the offloading at right time before complication, it is very important. And the second is adherence. Like sir said, patient is also a team member, because if he is not going to adhere with this particular protocol, whatever we are doing our best is we are not going to get any results. So adherence of the patient is very, very important, and we have to make them understand the importance of this adherence. Thank you very much.